Hello, my name is Billy Zhang. I'm the Vascular Ultrasound Marketing Manager at GE Healthcare and a member of the SVU Products Committee, along with Terry Case and George Verdejo. This program is being supported by an unrestricted educational grant provided by the Radiology and Vascular Ultrasound Division at GE Healthcare in cooperation with TIP TV. I will be giving a brief overview of both guidelines, and then Rob Daigle will follow with a comprehensive explanation of the upper extremity arterial duplex and physiological vascular examination. Upon completion of Rob's lecture, he will then demonstrate these techniques on a patient model. As I mentioned, we're going to look at two guidelines throughout this DVD. The first one is a physiologic testing guideline, which are going to be looking at arterial waveform analysis, segmental blood pressures, and pulse volume recordings. The second will really gear towards duplex ultrasound itself, and you're pretty comfortable with that, I'm sure, looking at grayscale imaging, looking at color Doppler, and looking at the spectral waveforms to denote whether we have disease or we have absence of disease. These guidelines are divided up into four distinct portions: the purpose of the examination itself, the indications of the examination, and the contraindications of the examination, and it finishes with the guidelines. So let's break up each one of those and look at each one separately. The purpose of both of these examinations is really to assess the upper extremity arterial system to determine the presence or absence of pathology and to facilitate clinical management decisions. Common indications for this type of exam, and they'll be very similar between the duplex and the physiological testing, will be exercise-related, pre-procedural assessments such as radial artery for coronary artery bypass or angioplasty and stent placement, evaluation of arterial trauma and or fistula, thoracic outlet syndrome, commonly called Paget-Schroeder, Raynaud's disease, limb ischemia or digital ischemia, follow-up to determine technical adequacy of surgical intervention, and follow-up of bypass grafts to detect intrinsic stenosis. Some common contraindications and limitations that will prevent you from fully getting the answers you need during the examinations are presence of ulcers, cast, and bandages, which frequently don't allow you to either wrap cuffs around the patient or allow the transducer access to the area that you need to visualize. IV catheters that limit access or visualization of the artery structures underneath of them, and the patient's inability to cooperate or tolerate the examination. Quite often during the upper extremity examination, you're going to have to position the patient in such a way to gain access to that area, and some patients frankly cannot move in those positions. The guidelines themselves, as I said, are divided up into 7 sections. The first section is the patient communication and positioning. It's very important at this section of the examination that you really explain what you're doing, tell the patient that you are going to scan the upper extremity. You may need to move them in certain areas during the examination. That ultrasound is something that is not going to hurt them at all, so they should be fairly comfortable with that. And that throughout the examination, you will continually explain to them what you are doing. The patient assessment is when you are clearly looking for some past history on this patient to help you get through your examination, make sure A, you're doing the right exam, and B, that the patient has given you a full analysis of what they have or had that brought them to your lab at this time. You will go over the risk factors, the results of previous studies, which are very, very important, I believe, to really kind of go back in the patient's data to see if they've had similar tests or other tests that would be complementary to helping you find whatever that patient came into the lab for. The guidelines itself, the examination guidelines, you want to make sure, and they will show you in this portion, that you're using the appropriate transducer frequency. Sometimes the patient will have large edematous upper extremity for various reasons, and you may have to drop frequencies. Typically, the upper extremity will be a fairly thin extremity as compared to the leg that when we're looking at the lower extremity leg, and you can use the higher frequencies, but sometimes to get into the subclavian or the innominate portion of this examination, you may need to turn to a curved linear transducer. Proper constant Doppler angle is very important. You want to maintain a 60-degree angle whenever possible. Never go above that 60-degree angle, always stay below it, and if you do go above that 60-degree angle, please take care in making sure you note that in your report. Look at spectral analysis and thorough analysis of all vessel segments. Examination guidelines continuing here, the Doppler waveform analysis of the brachial and radial arteries, subclavian to digital artery pressures you want to take, and once again making sure that Doppler angle is less than 60 degrees. That segmental blood pressure is very, very important to take on both sides and compare those, and take in the brachial region too to come up with an assessment of whether there's a problem between the cuff at the brachial level and the forearm cuff. And of course, we can also look at this with pulse volume recordings. After that, you want to review the diagnostic ultrasound exam findings. You want to present these exam findings to the interpreting physician so he can then extend the final report to the requesting physician, and with that, you should have a complete exam. The exam time recommendations for this, the duplex, the indirect portion, which are really bringing the patient into the examination, setting up the system, should take about 30 to 40 minutes. Scanning the patient itself will take a much longer, between 45 and 90 minutes. This can be a pretty complicated examination with the provocative movements that you may have to put the patient in to elicit the response of whatever problem they came into the lab. Physiological, same type of time frames, 30 to 40 minutes, and the direct assessment at 45 to 90 minutes. Continuing professional education is also a very important aspect of this examination, and as is with all examinations. Certification is considered the standard, and obtaining and maintaining CMEs is needed with that certification. These guidelines change frequently, and I suggest that you go to the SVU website at www.svunet.org to review these guidelines and to look for other guidelines that you may find interesting on these subjects. Thank you.
Hello everyone, my name is Rob Daigle, and I'm here today for our educational program on upper arterial physiologic and duplex evaluation. The indications for an upper extremity study include arterial insufficiency, or stenosis or occlusion of the central vessels, thoracic outlet syndrome, vasospastic disorders, and digital ischemia. We'll be discussing methods to address each one of these indications for the exam. Additionally, we occasionally see abnormal vertebral arteries during a cerebral vascular examination, and it's appropriate if the vertebral artery is abnormal to investigate the subclavian artery as well. And again, preoperative assessment, this can be either for hemodialysis access placement or for radial artery harvest for coronary artery bypass graft conduit material. There is a contraindication for our upper extremity evaluation, and that's in patients that have a hemodialysis access graft or a fistula. So we should not be taking arm pressures on that arm that has the dialysis access. Pulse volume recordings are okay. If you put the PVR cuff right over the fistula, and a reduced inflation pressure is appropriate, or we can obtain Doppler waveforms. These are all okay, but it's probably best to stay away from pressure assessment, at least over the hemodialysis access structure. Now, we'll do an anatomy review here. The aortic arch coming off the heart gives rise to the innominate artery on the right side. This is also called the brachiocephalic artery in some textbooks. The innominate gives rise to the common carotid artery and then the subclavian artery. This small branch coming off here is called the thyrocervical branch. We sometimes locate this with ultrasound when we're evaluating our vertebral arteries. And then also the vertebral comes right off the subclavian artery, courses up the neck. The common carotid on the left side comes right off the aortic arch, as does the subclavian artery. Subclavian again gives rise to the vertebral artery and then the thyrocervical branches, and then continues out to the arm to the axillary artery and down into the arm structure. So we see that the anatomy on the right side is a little bit different from the left, and that we only have one innominate artery, where interestingly we have two innominate veins. Now the anatomy on the arm consists of the axillary artery, and this goes from about the level of the first rib to about the axilla. Next is the brachial artery, and this courses from the axilla down to the antecubital fossa, right in this region. And right in the antecubital fossa, it gives rise to the radial artery, and this is a distal branch from the brachial artery that travels down to the wrist. There's also the ulnar artery. The ulnar artery comes again from the brachial artery and goes down on this side of the wrist. Then there's another vessel in here that we tend not to evaluate during our peripheral arterial studies, but it's called the interosseous artery, and this comes off the ulnar artery and courses right down between the two bones, between the radius and the ulnar, or between the radial artery and the ulnar artery. So this is a deeper vessel that's not always visualized. Now, the anatomy in the hand consists of the radial artery and the ulnar artery giving rise to the palmar arch. The palmar arch communicates between these two vessels, and the digital arteries come off the palmar arch. So obstruction, and we'll come back to this a little bit later, but obstruction in this palmar arch region can sort of affect our perfusion out to the digits, and it's one of the evaluations that we perform prior to our radial artery harvest. Now, the upper extremity arterial disease consists of atherosclerotic occlusive disease, and we tend to see this primarily in the subclavian artery. Mostly in the subclavian artery or in the innominate artery on the right side. The axillary, the brachial, the radial, and the ulnar arteries are usually spared this disease. Now, other types of disease that we can have in the upper extremities are thromboemboli or atheroemboli. If the atheroemboli is large, it can block a major artery, for instance, the axillary or the brachial artery. If it's a small atheroemboli, it can go down and obstruct the digital perfusion. These are usually of cardiac origin, or they may come from subclavian aneurysms. If they're a large emboli, as I mentioned, it can occlude the brachial artery, and if they're small, it's the small digital perfusion gets whacked by these small atheroemboli. Now, other extremity diseases are the thromboangiitis obliterans. This is also known as Berger's disease. This Berger's disease is an inflammatory process that causes thrombus of the small digital arteries in the fingers, and it can affect the toes as well. We see this most often in the fingers. This is primarily a fixed occlusive disease process. It's not so much a vasospastic situation. It usually occurs in male smokers. In fact, the primary treatment for Berger's disease is the immediate cessation of smoking to try and resume perfusion. So it's an inflammation of the arteries, which is the angiitis is similar to phlebitis. Phlebitis, inflammation of the vein. Angiitis, inflammation of the artery, in which the arteries thrombose. That's why it's called obliterans, and these small vessels stop perfusing the fingers. Another sign and symptom that we see is the Raynaud's syndrome. Raynaud's is an episodic digital vasospasm. This can affect the fingers, the toes, or the nose. Now, when for all of us, we have a response to cold in which the body tries to preserve core temperature. So it's willing to sacrifice perfusion to the skin surfaces in order to maintain this core temperature. So it'll vasoconstrict the small arterioles leading out to the skin of the fingers and the toes initially once we get cold. When the cold exposure is removed or we warm up, usually there's vasodilation and we get more perfusion back. But people that have Raynaud's syndrome, when they're exposed to the cold, there's a vasospasm that takes place, but it doesn't reopen. The vasospasm in the arterioles does not reopen once they're warmed. So it's kind of a intermittent but a persistent condition. So the typically affected area will turn white and then blue, and often when they're reperfused, it'll go to bright red. We can see these images on the right here. This is a person that's undergoing an episode of Raynaud's. Also, the symptoms can include, in addition to cold fingers and toes, numbness and pain. Now, there's about 40% of people that have the Raynaud's syndromes are associated with connective tissue disorders. That can be scleroderma, lupus, or rheumatoid arthritis. About 40% is idiopathic, meaning we just really don't know what causes it. About 20% is due to either previous frostbite or vibration injury or vibration trauma. This is a condition that's been reported in people that use jackhammers or drilling apparatus, in which the vibration can cause this to come about and occur. Now, I just wanted to point out something in that previous slide that from the Raynaud's Association website, about 5 to 10% of all Americans suffer from Raynaud's syndrome, but it's predominantly a women's disease. There's 9 times more women that suffer from Raynaud's than men. Also, it's estimated that about 20% of women in their childbearing years will have Raynaud's symptom at one time or another. Now, the Raynaud's syndrome is actually divided into 2 sort of categories. One is called primary Raynaud's, or Raynaud's disease. And primary Raynaud's means that this is a pure vasospastic disorder. Again, that's that idiopathic situation in which we really don't know what brings about this. There's no other underlying etiology or underlying cause for this. The second sort of division of the Raynaud's syndrome is called Raynaud's phenomenon, or secondary Raynaud's. And with secondary Raynaud's, this is usually due to some type of an underlying condition. As I mentioned before, this can be an autoimmune disease or disease of the connective tissue that actually contributes to this vasospasm. So the secondary Raynaud's can be treated. It's difficult to treat the primary Raynaud's. The secondary Raynaud's can be treated by treating the autoimmune diseases and the connective tissue diseases. Now, our upper extremity arterial disease, we also can evaluate for thoracic outlet syndrome. And thoracic outlet syndrome is an extrinsic compression of the subclavian artery or the axillary artery by some type of a structure in the chest. This can be the scalene muscle or the clavicle. Also, there's a giant cell arteritis that we deal with the upper extremities in our diagnostic world. This is called Takayasu's syndrome. This is a similar effect is atherosclerosis obliterans, but it's treated differently. It's treated more like an inflammatory process and with steroids rather than sort of the way we treat athero disease. And also, this is an interesting one. We sometimes see this in professional baseball players, in which from repeated trauma to the subclavian artery against the clavicle, they develop an aneurysm in the subclavian artery. And this can be the source of atheroemboli as well. So these are some of the other diseases that we look for. Now, the symptoms of upper extremity arterial disease are hand and arm weakness with exercise. The patient may have reduced or absent pulses in the wrist or the brachial pulse. They may have hand numbness, weakness, pain, and this can be position related. Also, ischemic fingers and cold sensitivity. We'll talk in just a moment about the different diagnostic methods associated with each one of these conditions. Now, in our diagnostic examination, the first step is to rule out proximal occlusive disease. In other words, this is going to be a baseline study for the other modalities of testing that we'll use. So we rule out occlusive disease primarily in the subclavian artery and the brachial artery or the innominate artery with a baseline physiologic study. And this can include segmental arm pressures at the brachial and the forearm or the wrist. We can do pulse volume recordings and or Doppler waveform assessment, just depending on what modality you favor in your laboratory. And then also, it's typical to do a digit pressure from the index finger of each arm as a preliminary baseline examination. This is a resting upper extremity study performed with pulse volume recording. This is the pulse volume recording from the upper arm, the forearm, and the right index finger. We can see the right side and the left side look pretty symmetrical. The right arm is 131, the left arm 125, so there's not a big gradient there. And then we've taken pressure measurements down in the digits here. This index finger is 129 and 123 for normal indices. So this is a normal, typical normal resting evaluation. Now, one of the primary things we look for in this baseline study is a pressure gradient between the right and the left subclavian, or the right and left brachial arteries, and this would indicate the presence of subclavian disease. So a 20 millimeter gradient between these arms warrants a repeat of the pressure measurements, because sometimes we get these pressures erroneously, and it's important to go back and recheck both arms. If there's a persistent 20 millimeter gradient, then we pay attention to our Doppler waveforms or pulse volume recording to confirm the fact that the lower side has subclavian artery stenosis or occlusion. So 20 millimeter pressure gradient indicates the presence of disease. Some people use a 30 millimeter gradient between the arm and the forearm in order to identify brachial artery disease, but I'll mention that brachial artery disease is pretty uncommon. Now, the second part of the diagnostic exam is we will tailor the exam to the specific conditions that the patient presents with. And this might be ischemic digits, it might be episodic vasospasm, or for the Raynaud syndrome, or it could be a positional situation in which the patient experiences the symptoms of numbness, weakness, or pain when their arm is in a certain position. So we'll evaluate them for thoracic outlet syndrome. Now, in terms of vasospasm versus small vessel disease, again, we rule out proximal disease. That's been completed. Then we perform a full digit study with pulse volume recordings or photoplethysmography, or PPGs, which can be conveniently placed on the fingertips. And then we also acquire digital pressures. This is a typical normal digit exam. This is an index pulse volume recording. I think it's PVR, yes, from the thumb, index, the middle finger, ring finger, and the small finger bilaterally. And we've obtained pressure measurements from all of these, and these can be compared to the arm pressures as well. So this is our baseline digit study. This is a normal result. Unfortunately, not everyone has such good waveforms when they come in. It's one of the reasons, particularly for upper extremity testing, that it always be done in a warm room, because there's so much vasoconstriction that takes place in the skin in a cold environment that this can provide low amplitude waveforms even on an otherwise normal person. So warm room testing is essential. Now, if we've done our examination in the digits, and the digits are very sort of low amplitude, then we're not sure if it's small vessel disease or if there's vasospasm taking place or vasoconstriction. So it's appropriate to warm the hand and retest. We've always sort of kept a heating blanket in our laboratory that we can wrap the patient and wrap the patient's hands in a heating blanket, and then we allow them to warm up, and then we go back and retest. Now, if there's no improvement in the waveforms, then we suspect that there's fixed occlusive disease. Let's look at a case of that right here. This patient presents with some ischemic fingertips. On the left side, the left digit from the middle finger and the left fourth digit, the ring finger and the left small finger, the amplitudes of the pulse volume recordings are quite a bit lower than the contralateral side. So we warmed the patient Here, this is just a cutout of that previous one, looking at the right side compared to the left. So we warmed this hand for 10 minutes. And this is pre-warming and this is post-warming. And following 10 minutes of heating with a warming pad, there was no increase in the amplitude of these waveforms. Now, if it's just a vasospastic kind of phenomenon, we would expect that the amplitude would get higher after warming. But in this case, we suspect that there's fixed occlusive disease or atheroemboli because the amplitude of the waveforms or the perfusion is not improved with warming. Now, for episodic vasospasm, if the patient comes in and they have somewhat normal perfusion, but they have an indication or history of episodic vasospasm, Raynaud's, we can perform the cold challenge test. And again, for this test, we obtain a baseline digit exam, as we mentioned, with pulse volume recordings or photoplethysmography, or there is some instrumentation that allows a temperature sensing infrared devices to record digit temperatures. So this can be used before a cold challenge and then after a cold challenge. We submerge the hand in ice water for 1 to 2 minutes. If you look at the older literature, they'll say for 5 minutes, but most people can't tolerate this. In fact, most people can't tolerate even a minute or two in ice water to chill down the hand. For this reason, one of my methods is to put the hand in cold water and then add the ice afterwards, so it's not quite as intimidating to the patient to see these small ice cubes floating around and having the hand plunge into the cold. So adding the ice afterwards tends to help, but the goal is to try and cool down the temperature of the hand and reassess waveforms following this cold immersion. It's also of interest, it seems to me, that people that actually have true Raynaud's phenomenon can tolerate a lot of cold submersion, where most of us can only tolerate a minute or two. Now, we retest after the cold submersion at 2-minute intervals. So we take the hand out of the water, we dry it out, we reapply our pulse volume recording cuff or our PPG sensor. Another method is to have the hand, it's been shown that by rewrapping the PVR cuff on the digit and afterwards, that it can introduce an artifact, and we may have the cuff wrapped on looser the second time or tighter the second time. So another method is to put the hand in a plastic bag with the cuff on, submerge that in the cold water. And that eliminates the variable of having to reapply the pressure cuff following the cold submersion. So whatever method, the idea is to acquire waveforms immediately following the submersion and then every 2 minutes following. Here's a normal study showing that this is the resting digit of one hand and the other hand. This is the right index finger, this is the left. Immediately post-submersion, there is essentially almost flat line here. So there's a vasoconstriction taking place, which we expect to find in a normal patient. And then after 2 minutes, the waveforms are coming back to coming back to some amplitude. At 4 minutes, and then at 5 minutes, I guess at 6 minutes here, the waveforms have come back to an amplitude that matches the pre-submersion levels. So that's a normal response to cold submersion. So when waveforms come back within 5 or 6 minutes following cold submersion, that sort of rules out that there's a vasospastic component that's causing the patient's symptoms. This is a case positive cold immersion examination. It's a little bit older study, but it was quite demonstrative for vasospastic disorder. This is a pulse volume recording taken from the right index finger. And this is the pre-submersion amplitude and morphology of the waveform. We immerse the hand for 2 minutes. Following the cold submersion, we did another PVR waveform, and the amplitude is quite reduced, as we expect. This is at 2 minutes. This is at 6 minutes. And we stretched this out to even 10 minutes. And this patient had still not shown any sort of improvement in the perfusion 10 minutes following this cold submersion. So they were in quite a bit of pain as well. So we ended up using a heating blanket to try and release the spasm. So this is what we expect to see in a Raynaud's cold submersion study, that either the amplitude of the waveforms, whether it be PPG or PVR waveforms, or the temperature, will not come back to normal for about at least 10 minutes. The literature says that normals will come back within 5 minutes, but I've usually found that people that have true Raynaud's, it's usually over past 8 minutes or 9 minutes for which their waveforms will come back to a baseline level, or perhaps not at all. Now, patients may present with non-ischemic digits. They may present with what's known as the thoracic outlet syndrome. Thoracic outlet is an intermittent compression of the brachial plexus, that being the vein, nerve, or the artery. It's usually caused by, it causes pain and weakness or paresthesia, numbness and tingling. And again, this thoracic outlet can be due to a well-developed musculature in this area, or the scalene muscle, or underneath the clavicle. There are a number of reasons why this can occur. About 95% of the time, this is a neurogenic issue, meaning that the nerve is being pinched. Only about 5% of the time is it an arterial vascular thoracic outlet. So when I think of thoracic outlet syndrome, I think of neurogenic versus vascular. So we test for the vascular. We don't have the capability, the vascular lab, to test for the neurogenic component. Now the methods are, again, to rule out athero disease in the arm, as we talked about initially. And then we can monitor the limb, whether the fingers or the wrist, with either continuous wave Doppler, or with pulse volume recording, or with photoplethysmography. And I'll come back to this warning in just a minute. Beware of false positives with this PPG method. We evaluate the limb in different thoracic outlet positions. So we start out in kind of a resting position with the patient sitting comfortably on the bed. We evaluate the perfusion to both arms. And then we evaluate in these different, what they call standard thoracic outlet positions. And that is with the arm abducted 90 degrees to the torso in this position. If you have the system capable of measuring things bilaterally, whether it be in pulse volume recording or PPGs, then you can do both arms at the same time. Otherwise, just do it unilaterally. A comment versus PPG waveforms versus pulse volume recording. It's been my experience that there's so much artifact in the pulse volume recording waveform, because when their arm is out to the side, they tend to tremor a little bit, that we don't get that tremor in a PPG waveform or the distal perfusion. So that's my preferred method for this. We then evaluate them with the arms straight up over their head. That's at 180 degrees above the head. We then evaluate in what I call the pledge position, and this can be turned into the Adson maneuver, in which we have in the pledge position, we have the patient turn their head towards the arm and then away from the arm, and we look for any decrease in the perfusion out to the hand of the arm. The next one is the stick-up position. This is elbows at the side with hands to the back, hands up with shoulders pressed downward and back, loosely referred to as the stick-up position, like you're being robbed. Give me all your money, put your hands up. So that's one position, but the most important position of any of these is the symptomatic position. Because if you have an abnormal finding in any one of these positions, it really doesn't mean a whole lot unless the patient is symptomatic. So whatever that symptomatic position is, we try and have the patient in that position. If we can elicit symptoms from them and we find that there's no decrease in the perfusion, then we know it's not a vascular thoracic outlet. It's probably neurogenic. If we find that there is a decrease in perfusion in their symptomatic position, then we can identify the etiology for that pain and discomfort as being a compressed artery. So symptomatic positions are very important. We one time we evaluated a violin player from the Denver Symphony one period in our lab who would develop pain in his hand when he was playing. So we had him bring his violin, and we set him up in the vascular lab, and we just let him play until he became symptomatic. And it was just the most relaxing time of the day in the vascular lab, because there was beautiful music just wafting through the lab. And we'd say, okay, should we go back and test him now? We'd say, no, let's give him another 5 minutes. So, but we went in, he was symptomatic. We tested while he was in that position, and there was no decrease in the perfusion. So that's a convenient way of ruling out thoracic outlet. Of all of these positions that we've discussed, the symptomatic position is the most important. Here's an example of a positive study. This is, again, he's using PPGs. We've recorded from the index finger of the right hand and the left side. We've recorded it in the resting position, 90-degree abduction, 180 degrees, tends to go flat line. Costoclavicular position, no change. This is the Adson's maneuver or the pledge position. And then this patient in the symptomatic position, the PPG tracing has gone flat line. So when we relieve the symptomatic position, have their arm down, pulsatility comes back. So in fact, that's a convenient way of testing, is to move their arm in and out of the symptomatic position and watch the perfusion stop and then continue when they're out of that symptomatic position. So whatever it takes to try and evaluate that position, that's the most important. Now, I will warn you that with the PPG technology, when we put this on the digits and we put our hand above our head and extend it, if the patient, some patients, if they hyperextend their hand, for some reason they compress the digital perfusion and they get flat line in the tracings on the fingers. After discovering this, I went back and looked at the literature, and there's a significant number of false positives reported for thoracic outlet using PPG. So it's primarily in that position, 180 degrees, arm above the head, and you hyperextend the hand, and you can shut off blood flow. So in that position, have them just relax their hand and not hyperextend it out this way to avoid that potential false positive. And if there's any question, you can also put a Doppler on the radial artery in that position to see if there's any compromise in the perfusion. With our physiologic study, we've been able to look at perfusion in the subclavian innominate arteries down into the arm, down to the digits. We've been able to evaluate for, separate out fixed occlusive disease versus a vasospastic disorder, and we've addressed our cold submersion as well as thoracic outlet. Now, there is a role for duplex imaging of the upper extremities as well. And duplex imaging of the extremities is very useful for identifying thromboembolus, particularly if the embolus is large and the symptoms are acute. We can often trace down and find the exact site where an embolus is lodged in a large artery. Also, we can look for specifically for whether an artery is stenosed or occluded. We can also look at digital arteries, and again, this is an adjunct to the segmental studies. The digital arteries can be evaluated with very high-frequency transducers. We sometimes use the intraoperative transducers for looking at the digital arteries, but again, only when they're positive by segmental studies for the small digital arteries. This is a normal subclavian artery showing a strong pulsatility, and I'll warn you that there's a lot of vasoreactivity in the arm. And when we look at a waveform from the subclavian artery or the axillary artery, if you watch it long enough, that waveform will change somewhat in its resistance pattern, depending on what's going on down in the hand. We see that in the radial artery quite often as well. But basically, the waveform in the subclavian is a high resistance waveform pattern with low flow in diastole or no flow till the next cardiac cycle. So that's pretty typical. This is a case of during a cerebral vascular examination, carotid duplex. It was noted that the vertebral artery on the left side was flowing in a retrograde fashion. So we're getting flow in the opposite direction here. So we evaluated the subclavian to try and determine, again, this patient had a pressure gradient lower on the left side than the right side by at least 20 millimeters. So we evaluated the proximal portion of the subclavian artery, and we were able to establish very turbulent flow, identify very high velocities. The velocity here was 240 centimeters per second, peak systole, and diastole was 68. And the waveform, of course, is very atypical for a normal subclavian artery waveform. Just a little bit distal to this point, out along the artery, we've got significant turbulence taking place, and actually we're more often to see this kind of a pattern initially in the subclavian, and then we go deeper with our sample volume to try and identify the stenosis. But a waveform like this is very consistent with post-stenotic turbulence, so we go back in and try and find the point of maximum stenosis. This is the axillary artery, a little bit farther distal on this patient, and we can see this abnormal pattern to the waveform. So that's a very common reason for doing subclavian stenosis evaluation when the vertebral arteries are abnormal. Now, a 56-year-old male presented with this next case. It's kind of an interesting case and somewhat unusual. He had a 4-day history of left arm numbness and weakness. He had no history of heart attack or myocardial infarct, no stroke. He had no history of hypertension. He was a smoker, smoked 2 packs per day. His physiologic studies on the left arm, physiologic studies were positive in the left arm. The right arm upper arm brachial pressure was 144, on the left side it was 88, and then 84, 74. And the right pressures were all normal. His waveforms were abnormal as well. So we sort of expected to find subclavian artery disease on the patient, because that's the most common site. But as we started to scan the subclavian, there was no disease present. We came down the brachial artery using color Doppler as our guide, and we identified this region of frequency increase with flow disturbance in the brachial artery. So we evaluated with our spectral Doppler. The velocities just before this region were about 11 centimeters per second in peak systole, and we moved our sample volume into the region of stenosis. The velocities went up over 2 meters per second, 223 centimeters per second, with post-stenotic turbulence. So an unusual, but nonetheless present brachial artery stenosis that initially diagnosed with physiologic testing, physiologic parameters, and then confirmed with brachial duplex. Now, another assessment, another reason for duplex imaging is for radial artery harvest preoperatively to coronary artery bypass graft. So the coronary artery bypass is starting to be used now more than the saphenous vein because it's more suitable for the size of a coronary artery replacement, and also the arterial walls are a little bit less inclined to develop intimal hyperplasia. So evaluating the radial artery preoperatively is one of our goals. Also, evaluating the patency of the palmar arch is important. And this is for either radial artery harvest or for hemodialysis access placement. Just a refresher on the anatomy, the palmar arch courses between the radial artery and the ulnar artery. It gives off the digital arteries. There's a deep and a superficial palmar arch that takes place. But not everyone has this anatomy that we just looked at. There are some people that don't have an intact palmar arch. The right radial artery is supplying the right digits, the ulnar artery is supplying the other digits, or we may have a situation where the ulnar artery is dominant and the radial artery doesn't supply much. So there are various configurations that we can look for. Now, for a preoperative assessment for this, we do bilateral arm pressures. Again, I mentioned that a number of times. 20 millimeter pressure gradient is significant. We do full digital pressures with PVR or PPG, or I should say digital evaluation. We can do pressures as well. I like to do what's called the quantitative Allen test. There's a subjective Allen test that can be performed by holding down the radial and the ulnar arteries and squeezing the hand a few times. But there's an actual quantitative test that I'll show you that can be done with PPG that's quite convenient. Then we also scan the radial artery for stenosis, for sclerosis, calcium within the artery, and then also measure the size of the radial artery. Now, the radial artery harvest contraindications are ischemic digits. Also, if there's vasospastic disorder in the digits, that they won't want to harvest the radial artery for that. If there's atherosclerotic disease in the arm, and then also sclerotic or small radial arteries may rule out that being used for the arterial conduit. Here's a convenient method of testing the palmar arch. We can put a PPG sensor either on the index finger and on the little finger if you have a bilateral system, or we can do it unilaterally. Some people will use the thumb for this as well. And we record a series of waveforms over with a long time sweep. At a certain period of time, right in this region that I've marked with these lines, we compress the radial artery and we look what happens to the perfusion on the index finger and on the little finger on this left side. And when we compress the radial artery here, we find that there's no significant decrease in the perfusion. So that means that the ulnar artery is supplying blood flow to all of these digits without any compromise. We then compress the ulnar artery, and we look for the same phenomenon. There's no decrease here in the PPG tracings with ulnar artery compression. So that means in this case the radial artery is able to supply blood flow through the palmar arch to all the digits and no compromise in the perfusion. So this person would be a candidate for radial artery harvest. Now, in this condition right here, in this patient, it's a different one, we compress the radial artery and we get a complete loss of perfusion to the index finger and to the little finger. And when we compress the ulnar artery, there's no change taking place. So in this case, by compressing the radial artery and shutting off blood flow to all these digits, this tells us that the radial artery is dominant in this patient. So the radial artery is supplying blood flow to all the digits, and the ulnar artery is probably not supplying much. So this is what we call the radial dominant situation. In this, again, here's the redundant image showing compression of the radial artery with reduced perfusion. So this person probably has a radial artery that looks something like this, or a perfusion in the hand that may look something like this. So in this patient, if they harvest the radial artery, this is going to be a contraindication. There'll be no perfusion to the digits. So this is a convenient method for testing preoperatively whether this palmar arch is intact or whether the radial or the artery ulnar artery is dominant in that particular patient. Now, to summarize the upper extremity evaluation, we have many facets of this examination, including the assessment for major occlusive disease. We also assess for digital perfusion, for small vessel occlusive disease, for vasoconstrictive disorders, and for thoracic outlet. So because it has so many facets, we need to do a baseline exam, and then we need to tailor the protocol for the specific symptoms to answer the clinical question for that patient. It's impractical to do all of these examinations on every patient in an upper extremity. So focus in after the baseline examination of what's important for that specific patient and try and answer the clinical question. I'd like to demonstrate an upper extremity duplex arterial evaluation as we discussed earlier in our lecture portion of the examination. We'll be evaluating the innominate artery, the subclavian, the axillary, brachial arteries, and then down into the forearm for the ulnar and the radial arteries. A point that I'd like to make when we start out in terms of transducer selection, because our model is so thin, I'll be using a higher frequency transducer. This, I believe, is an 8 to a 12 megahertz or an 8 to a 14 megahertz. On patients that are larger or obese patients, we may need to use a transducer that's in a range of, say, 5 to 10 or 5 to 12 megahertz, a little bit lower frequency to get that better penetration. So we get plenty of gel on the patient with good exposure here. Put some gel on the transducer itself. I'd like to start out in the carotid artery on the right side. In order to establish our anatomy and get the transducer oriented correctly, and here's our common carotid artery, subclavian, right this region, and now we'll start to follow it out this way. And now I'm absolutely certain that that's the subclavian artery distal to the vertebral. Then I'll turn on the color Doppler and sort of get around that excessive flash from the other vessels in the area. I'll try and elongate this as much as I can and follow it out distally. I think a smaller color box might help here. And I'll turn up our color gain. Now I'm struggling just a little bit to fill right here with color Doppler because it's starting to get a little bit deeper. So I've optimized the color scale. I've optimized our PRF, and I'm still having a little trouble filling this distal portion of the subclavian as it goes a little bit deeper. I'm going to see if steering the Doppler straight down will help. Sometimes we get a little bit more Doppler sensitivity and penetration when the Doppler is steered straight down. So in fact, I am able to fill this distal portion of the subclavian, but you'll notice also that I'm getting this artifact that's occurring just below the level right here. This is called a mirror imaging artifact. It's probably due to the ultrasound reflecting off the pleura of the lung. It's a common artifact showing up. Actually, we see it quite frequently on the left side. So this is an artifact, and this is the real subclavian. So I'll put our Doppler in here and evaluate this just as it courses underneath the clavicle. I'm healing and towing the transducer so that I can, even though I'm steered straight down, I can obtain a pretty decent angle here. It looks like I'm at about a 50-degree angle or so. Okay, so this is a very high resistant waveform, which is typical of the subclavian and axillary artery. Just a quick comment about the distal subclavian artery waveform here, at least the supraclavicular portion, is that we started out with a low resistance innominate artery waveform. We went to the subclavian, which became a little higher resistance, but it was still giving blood flow out to the vertebral, which is low resistant. And this portion of the subclavian, then from here on down, we expect to see this to be a higher resistance waveform with generally no flow throughout the cardiac cycle and through this region. This does vary quite a bit down in the brachial and the radial and the ulnar, depending on hand perfusion, but we'll look at that in just a moment. So I'm going to move the transducer over the top of the clavicle, and then we'll scan in a infraclavicular position and try and identify the subclavian artery in transverse view. And then we'll pick it up from there and follow it on down. Now, right in this region around the clavicle, another thing that we should be looking for, particularly on patients that may have been symptomatic for digital emboli or thromboemboli, is a subclavian artery aneurysm. These are pretty unusual, but if they do exist, most often they're in the region of the clavicle. So we try and pick these up just in the supraclavicular region and the infraclavicular region. And so that's something that is part of our routine diagnostic exam of the upper extremities. All right, I'm just over the clavicle. This large structure here is the subclavian vein. This is the subclavian artery. You can see that it's pulsatile. This is the shadow of the clavicle here. Now I'm going to turn the transducer longitudinal. Actually, as I turn the transducer here, I'd like to mention the orientation on the screen. When we start out on the common carotid artery, it's typical to have the thyroid to the right of the screen, typical to a carotid evaluation. And as we scan down into the proximal portion of the internal the innominate artery, I should say, that the innominate will be to the right and the subclavian to the left. So that's the kind of the normal orientation for a carotid exam, but it's a little atypical for a subclavian artery exam. So I tend to keep that orientation until I cross the clavicle. Distal to the clavicle, or the infraclavicular region, this is when we have the hand to the right of the screen on these arterial studies. We do that for both the left and the right, and it helps with the orientation of which way flow is supposed to be going. So again, this is the subclavian artery here. This is the clavicle right here region, and this will be the hand out towards this direction. So I'll look by the clavicle region here for any evidence of dilation of the artery, dilatation that may be associated with aneurysm, and that looks pretty good. We'll turn on our color Doppler in this region, steer it in the appropriate fashion, turn up our PRF scale. Blood flow is coming towards the transducer now from the left of the screen to the right, so we'll orient this so that it's red. And we'll increase our color scale a little bit. Now I'll interrogate right in this region very quickly. So nice clean waveform, typical of subclavian, high resistant waveform. So now we're down into the axillary artery. We see the triphasic waveform, red, blue, red, or at least multiphasic. And I'll do a quick sample here as well before I go to the axilla. So we see it's getting even more pulsatile as we come down the arm. So I'm sitting down now to evaluate the arm. Sometimes it's helpful to have a pillow out underneath your lap. We'll bring the arm out to the side so we can access the axillary and subclavian, or I'm sorry, the axillary and basilic and brachial arteries. So right here in the axilla, we see, I'll get the pointer on here, we see a vein right here collapsing, and we see another vein here, and we see an artery. So as I start to scan down a little bit, I see the artery give off a branch that most likely is the deep brachial artery, this being the brachial artery itself. We can see a nerve bundle right in this region, doesn't collapse at all. So I'll start to scan down the arm. Basilic vein is still close to the artery here. Now there's a arterial branch coming off right here, and I'm just down about 6 or 7 centimeters distal to the axilla, and I'm seeing another large artery come off here. One of the things that we look for in the upper extremity arterial exam, particularly on patients that may be a preoperative evaluation for hemodialysis access graft, or for those patients that may have a radial artery harvest planned for coronary artery bypass graft, it's important to note the origin of the radial artery, because in approximately 14% of the time it does not originate in the antecubital fossa. It originates someplace up along the medial aspect in the upper arm. So I think that's what we're seeing here. I'm seeing a division of the artery right here. I may turn on our color Doppler just to confirm that this is that these are both arteries. Because I'm transverse, I'll have to drop the PRF quite a bit. So we can see the pulsation here and here. So these are both arteries. Now this deeper one is most likely the brachial artery, and this superficial one is most likely the radial. But I won't know that for sure until I scan down and follow the course of these two vessels. Because technically, if the radial artery has actually come off at this level right here, this actually would, I suppose, technically be the ulnar artery. So let's follow this deeper one down. Again, we can see the artery right at the tip of the transducer. So now it's diving deep, as we expect the ulnar to do, and then it comes back more superficially. So I'm actually in the forearm. I'm identifying the ulnar artery here. I'll bring down my focal zones to show this a little better, maybe a little bit more depth. So this is the ulnar artery, and then the ulnar veins right beside it. I'm seeing a bifurcation here as well. The one that's going deep is the interosseous artery, as I mentioned in the lecture. This is a deep vessel that courses between the ulnar and the radial bone structures, and it comes off the ulnar artery. And this is just before that bifurcation. I'll put our Doppler in here. Look at the waveform to see if it's a typical ulnar artery waveform. She's got sort of an atypical 2 or 3 beats to this waveform, so I sort of refer to this as a multiphasic waveform, but again, typical high resistance pattern for these vessels at rest. All right, we'll go back up to that high confluence or high branch of the radial and follow that down. Again, I'll use the transverse orientation to find the vessel. And then we'll go longitudinal. Flow's going from left of the screen to right. So red is away from the transducer, so we expect our arteries to be red right here. And these are the two vessels right here. We're seeing the probably a brachial vein on the bottom. We're seeing the radial artery on the top, and the brachial or the ulnar now just below this in this image. So let's confirm this with a spectral Doppler at the origin of the radial. All right, so we'll follow this down. Also on the report, I would make note that this is a high branch of the high origin of the radial artery, and give the physician some idea of how many centimeters it is close to the, from the axilla. So this is following both of these vessels now. We can see them kind of lined up together. But right in the axilla, they'll go off in different directions. The ulnar artery will dive deeper, and it will go off on sort of on the little finger side of the arm, and then the radial will obviously come across towards the radial side. Is the ulnar diving deep, and the radial is the top vessel. One other thing that we would do if we were mapping this for hemodialysis access, or excuse me, for coronary artery bypass, we would look carefully in the radial artery for any calcium. So I'm on the radial artery now, down in the forearm, and I've identified the radial artery and transverse and gone to longitudinal. We'll put on our color Doppler, and I'd like to demonstrate something that I find very interesting, in that the radial artery and the ulnar, and for that matter the brachial, are very reactive. The blood flow reacts to vasodilation in the hand. And it happens quite frequently. It happens due to temperature changes, emotional changes. So the waveforms that we see in a radial artery can vary quite a bit. They can vary from a very high resistant waveform, like we're seeing here, to a very low resistant waveform, actually sometimes just before our eyes. So I'd like to demonstrate that. I'm going to have, once I get on the artery here, we'll look at the pulse Doppler flow. Okay, so this is the radial artery at rest. And Cynthia, can you just make a fist and hold it for a moment or two? So just having her make a fist, and then let's just release that. Just relax your hand. So we can see there's a dramatic change in the flow just because of the changing hemodynamics in the palmar arch and the digital vessels. So this has gone from a very low resistant flow, to high resistant to low resistant, just with some maneuvers of the hand. So this happens quite frequently. So that would complete our examination. If we were considering, as I mentioned, a bypass graft, we would measure the radial artery diameter from the origin to the mid portion to the distal radial artery to make sure it's of sufficient size for a coronary artery bypass. So what we've accomplished here in just a few minutes of the demonstration is to show the innominate, the subclavian, the axillary, and the vessels in the arm. Let me just reiterate that the purpose for this is to identify, number one, if there's subclavian stenosis. So if there's no subclavian stenosis, and we don't get that post-stenotic flow or high velocities, and for that matter, ditto for the innominate, then the next thing we may be looking for is the possibility of subclavian aneurysm. So we look carefully around the clavicle along the subclavian artery for that condition. Next, we try and identify if the patient has a high origin of the radial artery and if the radial artery is suitable for a bypass graft. So even though I've taken quite a bit of time to demonstrate all these sample spots, in reality the exam can go quite quickly with just sampling in 2 or 3 spots and using your color Doppler to guide you through for the presence of any flow disturbance. Hello. I'm going to demonstrate how to perform an upper extremity physiologic examination. Before we start the exam, though, I'd like to give you some advice, and that's the patient should be in a warm room, or the testing should be performed in a warm room, because if the room is cold, there's a vasoconstriction that takes place, and it makes it difficult to evaluate the digits. So this is the same rule that we use for the lower extremities. Test in a warm room for physiologic testing. It's very important. Now, I've already applied the blood pressure cuffs for this examination. We'll be performing pulse volume recording and obtaining blood pressures from the different sites of the cuff. We can also acquire Doppler waveforms from different sites along the arm. But for the purpose of this demonstration, we'll illustrate pulse volume recordings, or PVRs, as well as pressures from the different cuff sites. The cuff sizes are 10 centimeters on the upper arm, 10 centimeters on the forearm. We're going to just skip the wrist pressure for this demonstration, but normally we would use a metatarsal cuff or a pediatric cuff, and that's about a 7 centimeter size of the cuff. Also, we may use these digit cuffs. The digit cuffs are either a 1.9 or a 2.5 size. Now, we have a choice during doing digit examinations of either using pulse volume recordings from the digits, or we can use PPG, or photoplethysmography. For this demonstration, I'm going to apply these PPG cuffs, or sensors. These are little infrared light emitters that will measure the perfusion in the digits. So this is the left side and the right side. Okay, just relax your fingers there. Now these are very sensitive to light, ambient light in the room, so I usually like to cover up the PPGs so that we can reduce any artifact from room light. So it looks like we're getting a pretty good tracing on the right side. On the left side, our amplitude is just starting to come up now, so these look pretty good. Might drop the gain down just a notch. These look like normal PPG tracings from the fingers. So we'll capture those, and those will be stored in the system, and we'll move on to our next site. We'll skip the wrist PVR because we don't have cuffs there. We'll go to our next site, which will be the forearm pulse volume recording. We'll automatically inflate. And it takes a moment for the system to equilibrate as these waveforms start to come up above off the baseline, which we like to see. So they're symmetrical in height or amplitude. Also, they both have a reflected wave or a dichrotic notch. So we'll capture those, and these will be stored as well. We'll go on to the next site. The newer systems allow for bilateral accumulation of this information. Makes it a lot easier. A set amount of air volume is put into the cuffs to provide a pressure in the cuff of 65 millimeters of mercury, plus or minus 5. Okay, these look like good waveforms as well. There's no artifact involved, so we'll capture those. Just a point on pulse volume recordings, the patient should not be talking during this exam, and you shouldn't be leaning against the bed because this can introduce some motion artifact. The PVRs are very sensitive to any type of motion. Okay, we're going to go on to our brachial pressures. We've now acquired PVRs and PPGs from the index fingers. We'll go on to acquire the, starting out on the right brachial artery. Now, even though we're acquiring a brachial pressure, I find it much easier to obtain the pressure from the radial artery, or with the Doppler on the radial artery. Particularly on obese patients, it's sometimes difficult to find the brachial artery because of the size of the thigh, the lower arm. I'll hold the transducer at a 45 to a 60 degree angle, pointing up along the course of the vessel, and I'll acquire a radial artery signal. I also like to scan across the artery just to make sure that I'm in the center of the vessel and not just on the very edge of it with the transducer. Once I acquire a good signal, we'll inflate the right brachial cuff. We'll start to bleed back down, holding my hand very steady to not fall off the artery. Okay, so we started hearing that signal come back in. We'll measure the first pulse that comes in. That's the systolic pressure for the brachial artery. We'll bring this back to our marker line here. Looks like the pressure is about 130 in the right brachial. So we'll save that by going to the next location. and this will be the right forearm pressure. We'll use the same vessel, same radial artery for this. This is starting to bleed back down now. So these are the pulses coming back in. We'll head back to that first one that came in. I like to let 2 or 3 pulses come in so that we know it's not just a motion artifact, that we can actually see a set number of pulses. We'll save this. The pressure here is 122. And we'll skip the wrist pressure for the sake of this demonstration and go on to additional testing. Just going to back up. Normally we would take, when we have a cuff on the wrist, actually I think we can do this probably using the cuff that's on the forearm. We can acquire a radial pulse, a radial pressure as well as an ulnar pressure. So I think we can go ahead and demonstrate that. I'll just go back one here and do a do-over. Going to proceed with digital pressures. So I've applied the PPG clips to the index fingers, the right and the left side, and we're acquiring waveforms now. I'm going to cover these up with a cloth again. We've got our digit cuffs on. We'll inflate the cuffs until the PPG stops, bleed back down. When the pulses return, that first pulse that comes in, that's the digital pressure, the systolic pressure. We've obliterated the signal here. Now it will bleed back down. Okay, these are both returning now, so we'll do a capture and then we'll scan. I think we can do this with both images. We'll scan these back to the beginning so that we can mark the first pulse. So this is the first pulse on the right side. This is the first pulse on the left side. So it looks like the pressure on the right is 109, the left is 104. So we'll save those by moving on to our next location. So we've now accomplished a PVR study. We've acquired digital PVR signals, which both look normal, and our pressure indices on the right side, or our pressures throughout the arm on the right side, look normal as well. We're skipping the left pressures for the sake of this demonstration, but we've accomplished a good baseline study here. Going to demonstrate how to do a thoracic outlet test. And this is for those patients that will present with intermittent pain or tingling or swelling, whatever, with their arm in specific positions. So for this method, we can use either pulse volume recording, although there's a lot of artifact with pulse volume recordings when their arm is in different positions. I prefer to use PPG placed on the index fingers. For the sake of this demonstration in camera angles, etc., we're just going to demonstrate the right side. Normally, it's a very easy test to perform in a bilateral manner using bilateral PPG channels. So we'll start out with the patient in a baseline study, just resting, sitting up but resting. We're acquiring PPG signals here on the right side, and we'll capture that and then move on to the next site. Now we're going to perform the Adson's maneuver, and this is a maneuver that patients is sort of more or less in a pledge position, so we'll bring your arm up this way. And I'd like you to turn your head towards the transducer, towards the right. We notice on the right PPG that there's no change in the amplitude, or we expect something to go flat line. I'm going to capture that, and then we'll move on to the next site. The next site, same position, but we'll have you turn your head to the left. Again, good PPG signal on the right side, so no compromise there. We'll capture that one. Now I'm just going to have you rest your arm just for a moment. Sometimes resting the arm between these procedures helps the patient, because they can sometimes start to get a little tremor going if they hold their arm up for too long. We'll move on to our next site, which is going to be the costoclavicular move. This is with elbows back and hands up, palms out, sometimes called the stick-up position. So let's go ahead with that, Danielle. Sort of arms up, that's right. Elbows down. Okay, shoulders back. Okay, so we look at the PPG waveform on the right, no change. We'll capture that. Okay, just relax your arms now. So that's the costoclavicular position. We'll go on to our next site. This is hyperabduction, 90 degrees. So I'll have you move your arm straight out towards me. Again, we don't want to support the patient's arm. We want to let the patient put themselves in these positions themselves. Okay, we can see a decrease in the PPG tracing here. I'm just going to have you just relax your fingers just somewhat. Okay, straight out again. So these PPG tracings are starting to come back to normal now. Sometimes in the initial out position, there'll be a slight decrease in the amplitude. We'll capture that and then move on to our next site. And this is going to be straight above your head. Try and relax your hand when you go straight up. Just kind of up a little bit straighter than that. All right, we're getting a good signal there in the hyperabduction position, so we'll capture that and go on to the next position. So just relax your arm. Just a little warning on this PPG testing. There are some patients when they're in the 180 degree position and they superextend or hyperextend their fingers, they can cause a decrease in the digital perfusion, which is not related to the thoracic outlet. It's just related to the arterial complex and the digital arteries. So don't have the patient hyperextend their fingers. We want that somewhat relaxed when they put their hand straight over their heads. Okay, the next view, we'll just go back here slightly. The next part of the test that we'd like to do is to go to what we call the symptomatic position. The symptomatic position is the most important of any of the modalities, and that we want to have the patient into the position in which they're complaining of their symptoms. If we can show a decrease in the PPG tracing, particularly if it goes flat line, and they're in a symptomatic position, then we can relate that it's a vascular thoracic outlet with the symptoms. So, but if there's no change when they're in the symptomatic position, it's probably a neurogenic issue as opposed to a compressed artery. So let's go ahead into let's make up a symptomatic position here, holding textbooks or something like that, okay? Okay, these PPG tracings are still remaining pretty good amplitude, so in the symptomatic position, we ask, are you having symptoms? And if they are, we record this waveform, and this can rule out that it's a vascular thoracic outlet or an arterial thoracic outlet. Okay, we can just relax the arm there now. So again, we can usually do this bilaterally, but for the sake of the demonstration, we're just using it unilaterally. For someone that truly has thoracic outlet, we'll see that line go, PPG line go absolutely flat line.